Good afternoon, everyone, and welcome to this workshop in cost analysis in value-based healthcare. My name is Francisco Panaf. I am a junior economist here at Value for Health Collab, and I would like to start this presentation by thanking Salomé Azevedo and Ana Rita Londral for the opportunity to join the team that was already implementing cost analysis and for giving me the opportunity to present our results. As Sir Moore Gray said this morning, healthcare costs have been increasing, and one of the causes for that has to do with the increased number of new technologies and new healthcare interventions, which will contribute to increase the pressure on the healthcare budget. So conducting assessments of this type of new technologies and healthcare interventions is key to help decision makers to make the best allocation out of scarce resources. In this panel, we're actually going to discuss the costing part of this assessment. So typically, two different costing methodologies are used, one bottom-up or the top-down approach, and that will be further discussed in the discussion, but I would like to try to compare these two costing methodologies. First, regarding accuracy, that is the extent to which the estimated costs reflect the actual costs, and bottom-up approaches tend to be more accurate. However, top-down approaches are more feasible, meaning that they are easier to implement and to operationalize. Literature has not agreed yet on which methodology we should be used. So here at Value for Health Collab, as Salomé just presented in the previous discussion, we have developed a tool that allows collecting and analyzing outcomes, and we are currently working on upgrading that tool to be able to conduct a cost analysis. And I hope that in the next year's summit, we'll be able to present an app that will conduct a full value assessment of the interventions. So here at Value for Health Collab, every time we conduct a cost analysis, our goal is actually to answer this question. What is the total cost of care of the healthcare intervention for one patient? So our goal is actually to compute the cost per minute of each resource used during the healthcare intervention. And to do so, we rely on the time-driven activity-based costing methodology, which is considered a bottom-up approach, proposed by Kaplan and Anderson, and we actually base our implementation on the 7-step framework that they have defined, and we rely on a mixed method approach to be able to collect and to analyze the available data. So now I'm going to present two different use cases where we actually implement this TDABC methodology, and the first one has to do with the TDABC analysis of cardiothoracic surgery telemonitoring follow-up. As it was already explained during today, people in Hospital Santa Marta, which are submitted to cardiothoracic surgery, and during the first month after discharge, they have higher risks of developing post-operative complications. So during that month, they will be followed by a telemonitoring IoT kit. This is the first step. Now moving to the second one, has to do with the development of the process map of the patient pathway. And to do so, we conducted several meetings with hospital staff, doctors, nurses, clinical action assistants, and we were able to design this path and to locate the different resources used to each operation. So each small box here actually represents an operation, and this big purple one is the pathway that is followed by those patients who are being telemonitored, and this smaller yellow one is the pathway that is being followed by those patients who receive standard care. Just a note, this pathway actually represents the best case scenario possible. We are not considering, for example, any type of hospital readmission or any unscheduled appointment. And then we had to estimate the time, the duration of each activity. To do so, unfortunately, due to COVID, we were not able to shadow the patients and to follow them, but we conducted several focus groups with healthcare representatives of each HR category, and we computed the average duration of each operation according to their answers. So now focusing on the measuring costs. First of all, it's very important to mention that we are only considering those resources with direct contact with patients, and then we compute the capacity cost rate. And let me tell you, it's much more difficult than what I expected before. And now then we compute the total cost of the patient pathway. Now let's zoom in a little bit more on the capacity cost rate, which is the cost per minute of each resource used, and zoom in even more in the numerator part, which is the cost of the capacity supplied. And to be able to retrieve that cost, we asked the hospital human resource department for different costing information, and they gave us the total cost per year with each human resource category. And then we fortunately did not have the same luck yet with equipment and technology. So we had to go to the hospital and list all these resources and brands used, and then conduct an online search to be able to retrieve the acquisition value, the depreciation rate, and the maintenance costs of the different equipments that were used. For consumable resources, the hospital planning department provided us all the necessary costing information, and for spaces, this is actually fun. We had to go to the hospital and physically measure all the rooms that were used in the intervention to be able to compute the total cost of each of them. Now, moving to the second part of the equation, which is the practical capacity, meaning the time that each resource can devote to patient-related work, and then the computation of the capacity cost rate. Here, for the human resources, we asked the human resources department the number of working days per year and the number of working minutes per day. And according to the literature, we assumed an 80% of effective time because it is reported that 20% of the time is often dedicated for breaks or studying or education, which is not patient-related work. And then we computed the practical capacity and the capacity cost rate of each human resource, and the same methodology was applied to equipment and technology and to spaces. Now we are finally able to compute the total cost of the patient pathway. And now I'm going to just quickly present you some of our conclusions. Here we have, for example, the duration of the patient pathway, which activities or resources are more costly and that have to devote more time to them. And we conducted the same analysis for the standard follow-up. And here is a quick comparison of the results, but please keep in mind that we cannot yet take any conclusions because you have to input the outcomes to be able to conduct a full value assessment of that intervention. And then we conduct a very similar analysis, but this time into Portuguese private hospitals, CUF, for the knee osteoarthritis, which is a difficult word, surgery. And in this case, we didn't select the medical condition because the two hospitals were already collecting the outcomes for this procedure, and they asked us to conduct a cost analysis and a TDABC analysis, and we did that. So we had to design not one, but two patient pathways and obtain the time estimates for each process again. And then we had to adjust our cost simulator because public and private hospitals have different accounting systems and different rules. For example, regarding human resources, private hospitals rely on service fee contracts, which we did not find in the public hospital. So we had to adjust our method to include these costs. The same thing for equipment, consumables, and space resources. Very quickly present the results. Regarding pathway duration, we didn't find a significant change between the two hospitals. And regarding costs, the costs are also very similar between the two of them. So what we learned from implementing the TDABC is that cost-related data is dispersed among the different hospital information system, on the financial system, on the accounting, on the human resources system. So we must have a deep knowledge of the hospital IT infrastructure and the accounting methods to take advantage of the existing information. And then that involving all clinical and non-clinical hospital staff is key for the success of this cost analysis. And based on our experience so far, we are still developing and working on developing this study protocol based on the TDABC. And who knows if next year we'll be able to show it to you. So this is the team that allows us to continue to conduct this cost analysis. And Salme, now I'm going to give you the floor to hear your discussion about this topic.
Thank you, Francisco. Francisco is going to keep with us, what is going to help us not getting out of time in our discussion, which I don't believe it's going to take, because we are just we are few compared to the last panel, and I think I know most of you, and I know that you know how to talk on time, so I think it's going to be worth it. First, I would like to thank you all for being here with us. It's totally an honor. First, because it's a topic that a lot of people search for it and try to understand how to do it and how to use it in their organizations, both private and public. And the main goal of this panel was to actually have people from academia, people from private, people from public, trying to expose the problems in managing costs and trying to sometimes fight the myths related to costs, cost analysis in healthcare. So I will briefly present each of you, but I would also ask you to, in your 2 minutes of the round presentation, to go and give a deeper presentation and give more details to the audience, so the audience get to know you better. And because the main point of this workshop is to establish new collaborations and new relationship between stakeholders, so that would be good to do. And I will start with Etges, so professor in the School of Technology, Dr. Joana Feijó, which is the Business Development Director at the Health Cluster Portugal, João Leal, which is the information lead at CUF, one of the biggest private hospitals in Portugal, and also one of our founding partners at Voco Lab, and Professor Luigi Siciliani, which is professor at the University of York, which a true economist. And I think it's going to be super interesting to have all the details and all the experience so different from each other. I will start with Anna, if you'd like to present yourself and maybe talk a little bit about your interest in the topic and all your background, because you are the expert of TDABC in this panel, so no pressure in that sense.
Okay, thank you very much. It's a pleasure for me to be here today. Well, I serve as a co-founder at Way to Value, a company from Portugal that we created to advance this cost, not only TDABC, but cost analysis in healthcare, and also to connect technology capability to do it. In Brazil, I work as a professor in the Catholic University and also as a researcher. And as a researcher, the focus of my studies are TDABC and value-based healthcare. And this is the reason because last year, me and my colleagues and Professor Richard from Harvard, we created the TDABC in Healthcare Consortium. And the big goal of the consortium is to do this kind of things. And congrats for you create this moment, because we really want to make the TDABC better applied in healthcare studies for really develop better cost information around the world. This is something that I believe that is very, very important and it's necessary. And I have worked a lot to do it. Is my big goal during my research life. And I hope that during this panel, you can discuss challenges and opportunities in several countries here for we do it much better. Thank you.
Thank you. Joana, jump to you now.
Okay, good afternoon, everyone. Thank you, Salome, for the invitation. So, as you said, my name is Joana Feijó. I'm the Business Developer Director of Health Cluster Portugal. Previously, I've been working on, I'm from biomedics, and I've been working on medtech industry. I'm at Health Cluster Portugal for 3 years. Health Cluster Portugal is a private non-profit association that currently brings together more than 180 members, including R&D institutions, universities, hospitals, civil society organizations, and companies in the pharmaceutical, medtech, equipment area. And in Health Cluster Portugal, we start a project in 2017 regarding the establishment of value-based healthcare in Portugal. So different projects are ongoing in Portugal, but we as a stakeholder that represents and have as members the majority of our private and public hospitals, we thought that we could be a player very interesting to start this change of mind in the Portuguese healthcare model. So we start this project that have now 13 hospitals. Half of them are private, half of them are public, and we are working on studying the cataract surgery and another ophthalmology disease. And we are working on collecting outcomes from patients and see what is going on these different public and private hospitals. And we'll start collecting costs as soon as we can. This project have released the first annual report last year, with more than 10,000 patients in the report, and with results very interesting and compare with European ones and the results that the Nordic clusters have also. In March this year, we were recognized by the World Economic Forum, the Global Coalition for Value, as an innovation hub, meaning that we were selected as an interesting project that can be a proof of concept for other countries and other projects on how to implement value-based models on healthcare systems around the country. As I said, we are now working with 2 pathologies on the ophthalmology specialty, but we would our aim is to expand the project for different specialities and also to get inside the project more healthcare units in order to expand the model and get awareness of patients, NHS, private and public hospitals, and everyone on this new wave. And thank you.
Joana. Thank you. So I'll pass the word to João now.
Hello, everyone. Hello, Salme. Thank you for the invitation for Value for Health, for inviting CUF and myself for this talk. As I said, my name is João Leal. I am Data Analytics and Value-Based Healthcare Manager at CUF, which is a private healthcare provider that has been working in value-based healthcare for some years now. So we have been implementing some pathologies around our hospital units and private clinics. That gives us an operational perspective on how to implement value-based healthcare and what is the value that we can already extract from these processes. It is quite demanding. I'm sure that the conversation will bring us to some of the challenges that we faced. But of course, it's a pleasure to be here, and I hope to talk a bit further of our experience.
Yeah, definitely. Thank you, João. Luigi, please.
Yeah, thanks a lot for inviting me. So I'm a health economist at the University of York. My interests are mostly on policy evaluation, on evaluating specific health policies. So I've worked quite a bit on the role of competition in the health sector, how much patients choose based on quality as opposed to other criteria. I worked a little bit on the differences in quality provision between public and private providers. And I've also worked quite a bit on the waiting times, which I think is a big issue in Portugal as well. And I've looked at this both at the policy perspective and more research-based perspective. For example, looking at the effect of waiting times on health outcomes or waiting time inequalities and so on. I guess for the discussion today on value-based healthcare and cost analysis, there are 2 pieces that I was involved with. One was as part of the expert panel on effective ways in investing in health, which is like a European Commission expert expert panel. So we wrote there an opinion on value-based healthcare, where we tried there really to emphasize the health system perspective. So one of the first things that we did was to try to distinguish value-based healthcare from value-based pricing. Again, taking that health system perspective. And then in a different piece with the European Observatory, we also wrote about a policy brief, which is in the public domain, on value-based healthcare, where there we did one step further and we tried to emphasize a welfare perspective that would try to unify this concept of value-based healthcare. And because value, there are all these different meanings of values, we thought that this could be brought together through a well-being concept that would just unify everything. So that's my background and my interest in a couple of minutes. Thank you.
Thank you, Luigi. Actually, Professor Moore talked about the expert panel paper in the morning, so maybe you didn't have the time to see it, but it was really good to see the work that the expert group where you worked and he presented again. So thank you all again. And I think we are able to go for the second round, where the main point in here is I think it's going to be interesting because everyone has different interests and different backgrounds also. But the point in here is, why should we do cost analysis in healthcare? Why, contrary to the common sense, why is not being done in the right way, or is it being in the right way and we don't know? So I'm being provocative, okay, in that sense. Also, I would ask you for in each time that you will talk about opportunities and concerns that you have considering this topic, right? So, and I will trigger this. A low-cost patient is a healthy patient, right? Because it's not going to take a lot. It's not going to use a lot of health care service. Is it or isn't not? So I will give it to you this next round, these 2 minutes for you with your experience, basically that, and I will try to connect points between among you. What are the opportunities and concerns that we in healthcare should have in our minds to cost analysis, to cost control, and maybe destroy some myths about that if we start looking at costs, we are just looking at reducing costs and not managing costs, and that would have a lot of impact in resource allocation. And I think Luigi will have some words on that part of how to reallocate resources based on cost analysis and not reduced resources on that. And I think João and Joana also could give their opinion in the industry part, how cost analysis should not be seen as a bad thing, but as a good strategy to improve healthcare in that sense. Okay, so, and I will start with you again. So the round is fair.
Okay, no, it's a lot of things, a lot of very important questions, but let's try to organize. Well, the first question about why it's important. I usually say that in any business market, we know financial metrics is important, and why not in healthcare? That is the big point. And the fact is that when a few years ago and today also, we don't know costs. We know a lot about reimbursement. You know a lot of healthcare expenses, general expenses, but it's super hard. We know individual costs, like the cost to treat one patient. We know how much is being paid by the healthcare system to treat this patient. And when we try to advance in a value-based healthcare perspective, when we try to redesign reimbursement strategies, it's very risky. We redesign a reimbursement strategy without knowing the cost per clinical condition. And at this point, I see that the TD-ABC is very, very, very useful because it's a not very complicated manner to design the care pathway, to understand how each patient is consuming resources from the healthcare system. And at the end of a treatment and the end of the year, you can take a look and see, well, this patient is costing 100, 200, you can do it, you can measure that, and you can show and demonstrate for all the stakeholders the the cost composition. And this is very important in my opinion. I really don't like to talk about the global cost, but I prefer much more to discuss the cost composition, how it is costing, and how not only in terms of resource consuming, but in terms of during the care pathway where we are spending more money. And this is connected with the second question about a healthy patient cost less, and how can we manage that? Well, I have a few ideas about that. One is that we make people healthy requires investment. Like, you need to invest in health education, in health food, in provide sports, provide social entertainment. You know, you as the health system or the government and private companies also, you need to invest on that. And this is an investment for, we spend money with health and not only with treatment. Maybe the perfect world will be we have more money being used in the healthcare system to make people healthy than to treat patients with a very bad clinical condition at the end of the life. And I guess that this is our dream. Is not, obviously, it is not possible to achieve the maximum of this talk, but should be what we could work for every day for you achieve this kind of situation. And in terms of when we take a picture of nowadays, this sentence that we spend much more money with patients in a very hard clinical conditions, I guess that it depends of the clinical condition. For example, I'm working with stroke patients now, and after results that I'm applying the TDABC, and it's a very big cohort of patients here from Brazil, and we are showing that patients that died, they spent a long time to die and they cost a lot. You know, then this kind of things is cheap to die. No, that's not necessarily true. But I guess that the main point is we invest more in measure outcomes and costs, and we can use these results to manage better the healthcare system, for we have more money to invest in prevention and patient education, engagement, and a healthy life. And when we achieve that, we can save. You only can achieve that if you save money by don't allowing patients to achieve a very bad clinical condition at the end of the life. I guess that this is the main point.
Perfect. And I will jump to Joana.
So look into your bunch of questions.
You can pick one only. You can pick only one if you want.
Okay, so as everyone knows, the health costs represents a huge part of the national budget, and there are a lot of studies that shows that a part of the money that is spent on healthcare doesn't bring positive effects. So more or less 22% of the budget spent could be used to create innovation and have new therapies, new diagnostic tools, new treatments, or to create more healthy people by, as Hannah said, patient literacy, conditions in social spaces, or other kind of things. So everyone knows that it's important to measure costs and optimize what is going on the healthcare system. A lot have been done during the last years, but we think that everyone also think that we did not find yet a cost-effective way of doing it. This TDABC, it's the most interesting tool that we have, although has the previous your colleague said, it's very besides being effective, needs a lot of effort because it collects the data in a detailed way per patient, and we need to find here a sustainable way to do this. Why, if I think it's a healthy patient costs less, of course, I think it costs. There are also some studies on that, and besides that, it's a matter of human beings. So we want everyone to be healthy, and we are working to have that. Regarding opportunities and concerns, and looking to the project that we have here in HCP, introducing the cost analysis in the HCP health value-based project will allow Portuguese hospitals, the private and the public one, besides better understand the outcomes from patients. So what is the real clinical results of the actions of the clinicians? Also in the cost part, to detail costs at the patient level, to stratify patients' complexity, to increase cost information quality that will support to design value-based reimbursement and payments also. And also to identify opportunities to make the patient care flow more efficiently by analyzing the real resources that are applied to the patient pathway and improve the efficiency how they are used. Most concerns during these two years, my concern is the fear of people and institutions on giving access to data that allows other people for doing benchmarking. Benchmarking is a good thing. It's a road to improvement, a road to best practice and less costs with benefits to everyone, to all stakeholders. More quality of care to patients, less cost to patients, less cost to NHS, and also, as I said, funding availability to do new things, to have innovation on healthcare. And I think that with concerns, this is the most important, and I will keep for that for now.
No, it's perfect. So, João?
So yeah, measuring costs, of course, it's important in every business, in every market area. It's a way of getting some grip of what is going on and how good are we performing or not in terms of a financial, of course, perspective. But value-based healthcare also brings the perspective of measuring this alongside with the results to the patient and the clinical results. That's the main change of it. So we are not looking only in terms of a financial perspective, but also in terms of the results that this brings. That's the difficult part. Also, costs were already measured somehow in the market, in the healthcare market. But in a global perspective, we look into a hospital, into a ward or an OR room or something like that, and we know the costs and the operation that it takes to run these areas of the hospital. The trick is how to, as Joana said, change the mindset to a more granular level, to know for each patient, for each cycle of treatment, how much do we spend and what were the results. And that is a difficult change to do in terms of IT systems, in terms of the checkpoints where we want to measure this kind of information, but also it is a long and beautiful journey to go through, because this has a lot of opportunities. To have data like this in terms of costs, in terms of the treatment done to patient, in terms of outcomes to the patient is very reachful, and the trick will be, and I think in terms of the healthcare stakeholders, will be to know how to use this, of course, in terms of results to the patient, but also in terms of efficiencies and in terms of partnerships on the market. Because if you can show the same results or better with the costs contained, that would be a goal to achieve in terms of all stakeholders in the market, including the patient who in the private sector, of course, has a cost directly associated to it when there is not an insurance. So this is somehow the difficult part of it, but to measure costs it's a must do. So I think the market must evolve to measure in a way that is comparable, as Joana said. Also, benchmarking is very important. But if I measure some costs and other hospital is more important to measure other costs, and we cannot compare the practices, it's not valuable. So CUF is working with ICHOM, with the standard sets that allow us to know which pathologies to measure in a standard way, in a comparable way with the market. And of course, the cost part it's not determined, but we want to measure alongside those pathologies and alongside those methodologies so that we can compare with each other's in the market as soon as possible. So yes, benchmarking it's paramount for the market to evolve as a whole, and we are keen on investing in that. Of course, when looking into the healthy patients versus acute patients, the market is still very fond of treating patients, as Anna said. We are looking into a market that has hospitals, inpatient treatments, and everything like that. But of course, private and public healthcare providers are working already in a way that we can follow patients in their journey, not only in acute episodes, but also in terms of well-being and in terms of chronic diseases, for instance. So of course, there is a way of doing that. We must come out of the hospital walls. We have to have ways of measuring this data outside the hospitals, having the patients to participate with data, of course, for this. And alongside that, the costs, of course, will come up, and then we can do a cost-benefit analysis as we do with inpatient information. So that's one way of doing it. It's not easy, but there is already some bits and pieces. The final message for this question, I think it's important to share, is that we don't have to start with bazooka to treat value-based healthcare and to have somehow a cost analysis. It's very important to start measuring some costs, the ones that are most impactful in terms of the clinical pathway or in terms of the patient treatment, and to measure those costs along the time will be certainly will be useful. We don't have to measure every cost at every time with every HR that is participating or every material. That's not the purpose of it. We have to measure what are the costs that impact the clinical pathway and, of course, the results to the patient. If we start small, the results will come up, and of course we can gather more costs and more data points along the side, along the clinical pathway for time. So that's the message.
Thank you. Luigi?
Yes, thanks. So I was trying to answer your question, so I'll try to do that. So I think one question that you put is like whether we should focus on improving, we should just focus on improving outcomes. But I think here, at the health system level, it's quite easy to argue that precisely because you want to improve outcomes, you should look at cost, because that's the way. By looking at cost, you can identify whether the resources are spent efficiently, and actually you want to free up these resources so that then you can reinvest them to improve in the health outcomes. Otherwise, you could be, if you just focus on health outcome, you could be spending like a huge amount of time on some amount of resources on some treatments that provide positive but very little benefits. So by reallocating those resources, which you can do only by looking at cost, you can actually maximize the health outcomes. So in that sense, I think it's quite easy to make that argument. And I think this holds both for countries that have a national health service, that have a fixed budget. And I would say any publicly funded system which has a slightly more open-ended budget, that will still hold, in the sense that you still want to reallocate. I mean, maybe that doesn't, probably only if you would be in a complete private health insurance market, maybe you wouldn't worry so much about that. Though actually, if you look at Porter, the concept of value-based healthcare, he argues that even in that case, then precisely you would want to look at the ratios between the cost and benefits. So that was the answer to the first question. The second one related to at what level you should measure costs. So there, I was thinking. I mean, most of the examples I've seen, they seem to relate to the provider. You're measuring cost for the provider, which in itself seems to be quite challenging. But you could also ask more challenging questions which relate. Should you also include some costs that are not strictly in the health sector, but they could be in the community? So strictly is not the health sector, but they still, if you think about the cost of treating a patient, there might be some costs that are outside of the health sector. And you think then even more in the less formal sector, if you think about the informal carers, well, then possibly you should include even the additional cost that informal carers might have, that maybe they are not monetary costs, but they are, they might still affect their well-being. Some informal carer might have, may be at a higher risk of depression, after many years of taking care of someone. So in that sense, a more comprehensive cost utility analysis or cost effectiveness analysis or a value-based healthcare analysis, you could include, you could have a more comprehensive concept of cost. So in that sense, I would encourage to think a bit more broadly, not only for the provider cost. I think that then one of the last question was related to whether the citizens and the patients should know the associated cost of care. And there, I don't see any problem with that, in the sense that in some countries, probably social health insurance countries, where you have co-payments, maybe like in France, the patients can already see the cost of healthcare because they have to pay a proportion. You're sent often a detailed bill where because they have to calculate how much you have to pay. So to me, this is not a problem that patients and citizens have access to this information. So in that sense, maybe I was curious to know what you thought were the concerns about providing this information. But I agree that in many, especially the National Health Services system, patients do not have access to this information.
Yeah,
okay.
that was it. Yeah, now thank you, and that was it. I was going to finish with that question to all the guests also, and ask for because there's each panel had a challenge to the other panels, and you have been challenged from the other panel. I was going to ask Luisa to tell that in a bit, and then I will quickly go to Luigi because we have shortened time. So Luisa.
Okay, so this challenge was from Patient Pathway panel, and it is: how can cost analysis identify lacks in care services and guide resources reallocation to meet the real needs of patients?
So I think we got more or less everything. So it was good. It was good. So we've been challenging it well. But I would like to take the last 5 minutes. I think I still have 4 minutes, Luisa. So
yes,
4 minutes to take the last question of Luigi, because I think it's really important. So in Portugal, João, can you give a little sense of what are the costs that patients are able to see? And what are the difference between those costs with the actual cost that the hospital, the provider in this case, have it? Because now I'm going to talk as a citizen, not a researcher, not even an expert in this area. When I go to the service, I don't see actually everything that is involved with a cost. So in the public hospitals, the feeling that we get that when we are not studying the economic part, we don't see actually what are the costs associated with the service. So we try to underestimate or the real service that was provided to us, and that was the question that we had for you guys. It was actually to go straight to the point to that. In public, I don't know about private, and I will let João add on that part, but in public, in Portugal, citizens don't know what it costs for a care service. So it can have hazard, or it can make patients can make bad decisions because they are not aware of how much it costs and take it for granted most of the exams or most of the appointments that they have, and they are not cautious enough to act upon it. But I will let you, the other three guests, to have an opinion as an expert or as a citizen trying to figure out if they should know the costs or should not know the costs. But João.
Okay, thank you, Salme. Of course, I think if we want to be a better informed population, we should have access also to the costs that healthcare has. I can speak as a citizen also, and as someone that worked in the Ministry of Health before CUF, so I have the public and the private perspective. And the costs are not upfront the patients, and that's not a good thing. There should be somehow a way of telling people how much their treatment, not in a way that they feel heavier for having these treatments or bad, that's not the point, but also to include the patient in some decisions. In terms of the private sector, it's a little bit different. We still work in Portugal mainly as a fee-for-service. There is still some bundling, but that's not the most of the activity. So everything that is done, a patient has the perspective, or the insurance company that pays for the patient has the perspective of what was billed and what was done to the patient. So that's more a direct way of knowing how much something costs to the patient. But even there are some hidden costs that the healthcare sector has, and the patient does not know. The operation of a healthcare sector is very expensive. The materials, the pharmaceuticals, everything that the HR, everything is very comprehensive. And I think that the information should be given to everyone, to the population in general, but in an informed way so that they can have better decisions. It's not to make someone afraid of going to the healthcare sector or to run from the treatment. It's not that the point, but to make better and informed decisions, and to have clinical results alongside the costs would help with that. Not only the costs, I think to give just information about the costs would be somehow empty and would lead to misunderstanding of how good some treatment could be or not compared to the other. So healthcare costs should be aligned with the results, the clinical results and the patient results for the treatment.
Thank you, João. Joana and Anna, we just have 2 minutes. If you could split 1-1, it would be good. So Anna, can you start?
Yes, I can go. And I agree, I guess, that if you want to include patients in much more in the decision-making process of the healthcare that he's receiving, I guess that he has access to the financial information. It's important. Also, if you think about general and country outcomes panels, we have a financial metric associated with clinical outcomes is very useful. I guess that it is important patients know about how much it costs. I don't know if cost is the best measure, maybe could be expenses, hospital charges. We can discuss much more about the best information, but patient has access to the financial information in a general perspective. I guess that only contributes for they be educated about the healthcare system.
Thank you, Anna. Joana.
So in
30
1 minute,
seconds.
30 seconds.
I'm joking.
In all the projects that I have been involved, they all go to the same point. Patients need to be on the center. And when we say this, we say that we need to measure their outcomes. We need to have a patient more engaged on their treatment and on keeping healthy. We need to have a patient knowing about having digital literacy to allow for digital treatments and digital monitoring. And we need patient also engaged to donate their data for secondary use. So patient in the center is the most important thing now on the era that we are. And of course, they need to know not the costs, the expenses of the treatment and the results of the treatment on patients like them. So yes, of course, I think that the patient needs to be on the center and knows everything that he can understand and turn on information to take more decisions, more capable decisions. And that's the message.
Thank you. Luigi, I don't know if you still want to add anything more. It's 10 seconds and then I have to close. I'm sorry.
Yeah, well, I was going to make some other remarks, but yeah, I think the question on the challenges was a very important one. I think, you know, this economic evaluation, they are only done on a very small subset of treatments. And when you move to prevention, you know, there are also other challenges to evaluate these interventions, which are even greater. And the last challenge I think that we really need to address is equity, because I think we always talk about equity as a policy objective, but then it gets lost a little bit in the implementation. So I think we need to find a way to bring it in a more practical way. Thanks a lot for having me today.
And thank you for pinpointing some incredible details. I wish we had at least more 1 hour or two so we could discuss that, because that would be the next point for sure. But this year was more focused on cost analysis in the operational part, and maybe next year we have more results to discuss and go to the right decision making policy concerns which involve the results of this kind of cost analysis and what is the impact on providing treatments to all patients, regardless their characteristics and their limitations. So once again, it was really an honor to be here with you in this panel. I hope you enjoyed. It's always a difficult topic to discuss, but we are trying to make the first steps at the collab, and let's see if we could collaborate in the next years. Thank you all.
Sure.
Thank you.
Thank you.
Salome.
Thank you very much.
Bye all. Thank you.
Bye.
Bye.
Thank you.
Bye.
Bye. Bye.